Hi, good evening. Welcome to another episode of Ask Paul Anything, where you can ask anything and Professor Paul Tambaya will try his best to answer your questions. I'm Alfred Tan, your host for this episode. Now, SDP has put forth an 8-point plan to move Singapore past the COVID pandemic and transit us into the new environment where COVID will continue to live with us in our world. We've asked to hear your views, your concerns, and in this episode of APA, we will highlight some of your concerns and will clarify and address them. Professor Paul, before we go into the 8-point plan, let's discuss a bit about the present situation.
Sure.
We hear a lot about living with the virus. Why is it possible for us to do so now in Singapore?
Well, the sad reality is that we have no choice. Because Bertha Henson, who's my colleague at NUS, she actually gave a very good analogy. She said the virus is like an unwelcome guest, came into our house in January 23rd, 2020, and refuses to go away, despite all our efforts to chase it away. We've tried all kinds of trying things, we've tried to restrict it, we've tried to drive it out. Not only does it not go away, it brings all its friends, relatives, and different variants, and it's been taking over every room of our house. So we have no choice but to live with the virus, and what we need to do is make sure it doesn't do any damage, that it doesn't eat up everything in the fridge, it doesn't destroy the furniture, and I think that's as far as the analogy can go. So basically, every country in the world, with the exception of China and probably Hong Kong and Taiwan, have recognized that the virus cannot be eliminated. So all the other countries have gone away from a zero COVID strategy to try and focus on living with the virus, preventing illness and death, and protecting the vulnerable.
So in Singapore, we can do that because we have no choice.
Well, we have no choice. I guess it's the other way around. We have no choice, so we have to come up with the best way of dealing with it. And this is what the 8-point plan is actually all about. It's not using the same strategies that we used 1.5 years ago, but recognizing that now we get increasing numbers of cases, we're getting increasing numbers of deaths, and so we really need to protect those who are at risk of death, rather than being super kiasu and trying to eliminate every single case, or overdoing a response to just one case of the virus.
Well, there are reports that compare the COVID with the influenza, the seasonal influ. How similar is this COVID?
Well, in terms of symptoms, both COVID and seasonal influenza start with sore throat, running nose, cough, headache, tiredness. And both of them can lead to pneumonia, which can be quite severe. They can also affect other organs such as the heart and the brain. The big difference is that COVID is new to the entire world since December 2019. On the other hand, influenza has been around for hundreds of years. So our bodies, our immune systems have dealt with influenza, and we have learned how to react to it. The other big difference is the impact. Now, COVID has got a disproportionate impact on elderly people, where you find that they do a lot worse than if they got the flu. But on the other hand, the paradox is that children actually do better with COVID than they do with influenza. All over the world, there are hundreds of children who die from influenza every year. But the number of children who have had severe COVID has actually been really a handful.
Okay. So it's almost similar to a seasonal flu in terms of some characteristic.
That's right. So it's very hard to tell the difference. You need to do a PCR test or an ART to tell the difference between flu and COVID. But the interesting thing is that there's been no flu for more than a year in Singapore. The last case of flu was May 2020. We had one case in July this year, and that's about it.
And why is that so?
And nobody knows. In fact, I have a PhD student trying to figure that out.
Well, with COVID, with the vaccination, there are asymptomatic cases, and there are so many in Singapore, they will be running all over Singapore. Isn't that dangerous?
Well, again, yes and no. I mean, asymptomatic patients transmit the virus, but at a much lower rate than pre-symptomatic or symptomatic individuals. The other thing is it's really, really hard to stop. Because once you've got 2,000, 3,000 new cases every day, it's impossible to do contact tracing for these individuals. And so basically you have to assume that everyone that you meet is pre-symptomatic and is going to get the virus in a couple of days' time. So you've got to take precautions, you've got to make sure you're vaccinated, you've got to look after your health and monitor your condition as well.
Just to remind us, how is COVID transmitted again?
Yeah, so COVID is primarily transmitted by close contact. The highest transmission rates are in families or in households. And unfortunately, our poor migrant worker brothers who live in dorms, you've got rooms with 15, 20 people in a room, so it's very easy to spread that way. The other modes of transmission are through droplets, through coughing, sneezing, talking, and rarely you've got fomite or surfaces, and in occasional situations it gets aerosolized over distances, but primarily close contact.
Okay. So what you've mentioned, the mode of transmission, they are also similar to the
Very, very similar to the flu. In fact, that's why a lot of the efforts to control COVID are actually based on studies that were done on the flu.
Okay. All right. So with that in mind, some of us are concerned that, it's okay to test less. Is that a wise thing to do?
Yes and no. I mean, I think what we need to do is we need to be smart about the testing. So we do what's called sentinel surveillance, and that has been done for influenza for a long time. They do surveillance on select polyclinics, they do surveillance among children, they do surveillance in KK.
So that's already been done for flu?
For flu, exactly. And so we should continue to do that for COVID. They are doing some of that for COVID, for people who show up in the polyclinics with respiratory illnesses.
Okay.
Even if they don't ask for a COVID test, some of the COVID tests are done for surveillance purposes. But we don't routinely test people with dengue for asymptomatic people for dengue, even though more than 90% of dengue is asymptomatic. And in fact, you can spread dengue when you're pre-symptomatic. We've reported a case of a guy who went to give blood, and the next day he got a fever. And he was very responsible. He called the blood bank. But unfortunately, the blood had already been used.
Oh dear.
And then 3 people got dengue from that blood donation.
Okay.
So it's a very rare situation where you get severe illness with dengue. But the reality is that asymptomatic dengue occurs all the time, every day. I mean, we know that from the surveillance studies that we do, but we don't test for it. And what we do is we focus for dengue vector control, identifying the severely ill cases and making sure they're treated appropriately. And that's what I think we should do for COVID, although there's no mosquito involved.
Yeah. But it's close contact.
The same principles,
right?
that's
Yeah.
right.
All right. Well, with asymptomatic cases running around, and one of our suggestions was to visit your clinics, if you don't feel well, instead of visiting the hospitals and A&E. Wouldn't that cause more infection? I mean, we have other people visiting the neighborhood clinics. I mean, are we exposing ourselves?
I don't think so. I think you're far more likely to get infected at A&E. From that point of view, you go to a clinic, the most you wait half an hour. Wait 15 minutes, you get bored, you go to the next clinic, right? So the clinics are there where the people are. And the clinics are very well organized. The PHPC clinics, I brought my mom's domestic helper to a clinic. I was very impressed. They had a triage station, they had temperature taking, they had PPE for the staff. So, it's been more than a year and a half into the pandemic. So the primary care clinics, they have got a good sense of how to deal with patients. If you've got a cough and a cold, most of them will put you outside where there's cross ventilation. They don't put you in the same place.
Yes.
So at the registration desk. So I think it's a lot safer than going to A&E, where you could end up waiting 8-9 hours, and then I mean, A&E also, don't get me wrong, they have very good protocols. They separate the patients, but somebody could come in with no symptoms, and then after a few hours they start showing symptoms.
Sure.
So you can't be sure.
All right. Yeah. Anyway, there are more clinics around, right?
Oh,
They
definitely.
can spread the load.
Yeah,
a lot.
clinics are every HDB block has probably got a clinic nearby.
Sure. Then we talk about home recovery. We have this home recovery protocol. If you were to recover at home, wouldn't you spread to your immediate family members? I mean, isn't that multiplying the virus?
Yes, it does, but the sad fact is that the virus is most infectious day -2 to day +2. So in other words, before you got symptoms, and most people don't get tested the minute they get symptoms. They get tested on day 1 or day 2, after about 1 or 2 days of symptoms, then they get tested. So that's already 4 days that your family's been exposed. See? So by the time you decide to go back after you've been identified, it's too late.
That's right.
They're going to show the symptoms
That's
sooner
true.
or later.
Yeah. Okay. All right. And well, there's also discussion of blanket-wide lockdowns versus specific location restrictions. How you reconcile that? I mean,
Well, basically blanket-wide lockdowns, they cause a lot of hardship to small business owners like yourself. And they also, yeah, exactly. And they are not effective, because we've seen this with hand, foot and mouth disease. There was a period when we had a very severe outbreak of hand, foot and mouth disease, 2000, 2001, I think it was. They closed all the childcare centers. And it was chaos because the parents had to stay home with the kids. And even the kids have to go somewhere. So the kids end up going to the playground and they start spreading hand, foot and mouth disease just as much. And this is worse because you're not just spreading it within one childcare center. The kids in the playground come from multiple childcare centers. So similarly, if you close all the malls, you close all the people still need to find a place to go and get food. They need to get supplies. So there's going to be some mixing that occurs. The only lockdown that really works is the kind of lockdown they did in Wuhan in February 2020, where the whole city became a ghost town. And that is pretty devastating. It was devastating, but they were able to do it for a short period of time and to really have an impact on the virus. Frankly, I don't think any other city anywhere in the world has tried to do that. And similarly, they haven't had the same kind of results.
Those were the early days, and I guess
right.
that's appropriate for zero COVID.
Exactly,
Right?
when there was like a few hundred people with the virus.
Yes. Okay.
Now we've got, 200 million people who've been infected. There's just no way it will work.
Okay, all right. Now, public transport. Well, there are asymptomatic people running around Singapore. They are taking public transport. Isn't that dangerous?
Well, yes and no. I mean, the one thing about Singapore is that it's small. So generally, the rides on public transport are relatively short. There have been documented transmissions on public transport early in the epidemic from China, from other parts of the world. But these are long rides, a few hours, where there's plenty of opportunities for contact. There have actually been very few studies on transmission in short rides, like in New York City or in London, for example. But we see a lot in the long distance rides. But there's no logical reason why public transport is not going to be a place where the virus spreads. So personally, one of the nice things about when we had the heightened alert is that on the times when I did have to take a train, I always got a seat, which because there are fewer people going on the train.
Right.
So if they can actually increase the frequency of the trains so that you don't have to be so crowded, then I think that would actually have a public health impact as well.
Okay. So not so much of a concern in public transport in Singapore.
Well, again, theoretically there is a concern, but there's very little solid evidence about it.
Okay. I guess don't remove your mask.
Yeah.
Don't talk.
Yeah. Don't talk.
Yeah.
We don't know, but don't remove. I mean, wearing a mask, I think, is definitely reasonable.
Okay. All right. Oh, why is it so important to take into account the mental health aspects of the population when we manage endemics like COVID?
Well, mental health is a very much neglected part of overall well-being. It's only recently, in the last few months, that it's come to light in Singapore. In fact, literally, some of the buildings have been colored blue. That's to highlight this issue of mental health.
Oh, yes.
But frankly, I was talking to a mental health professional a couple of days ago, and she said, frankly, if I had a choice between coloring a building blue or getting more staff to look after people who have mental health problems, I'd much rather take the staff who can deal with the issues, because the waiting times for clinic appointments for public sector psychiatrists are really long. So, but mental health, isolation, humans are social animals. We depend a lot on interaction with individuals. And this is especially true for older people. So in fact, if I had a chance to lift one of the restrictions, one of the first restrictions I would lift is the number of visitors visiting an older person. Because, people are responsible. They know that they have to protect their vulnerable friends and relatives. And, they can always do an ART on their own if they want to, and they can stay away if they're unwell. But for the poor older person, especially those who are living alone, it's a tremendous hardship for them. And we've seen cases of people who are very ill. They don't complain because that generation didn't complain.
Yes.
And then they wait until they're really, really sick, and then somebody finds them and then brings them to the hospital, and it may be too late.
Yes.
And that is something we really want to prevent. So mental health in the young, mental health in the elderly, mental health in the vulnerable, these are all really, really important.
Especially when in an endemic situation, things really dragged on,
Right.
right? And if you keep prolonging this isolation, I think it creates madness.
It is. It's terrible.
Right. The other big topic that has been going around this few weeks is about vaccine discrimination. How do you justify and reconcile such discrimination?
Yeah. So again, this is a complicated issue. We do have vaccine mandates in Singapore. We've had vaccine mandates in Singapore for many years for primary schools. So for primary schools, you need to have measles vaccination and you need to have diphtheria vaccination. Interestingly enough, polio vaccination is not compulsory. But we have more than 97% polio vaccination rates, and we have eliminated polio in Singapore, even without a mandate. So there's some argument that mandates may not be necessary, that people will do the right thing because they want to protect themselves, they want to protect their family members. But that's because we got a super effective vaccine. And the two polio vaccines are both highly effective, and they actually complement each other.
Right.
Now, the vaccines that we have are highly effective at protecting you from severe illness and death, but unfortunately, they are only modestly effective at preventing transmission, and they're really hardly effective at all in preventing infection. So they are very much a version 1.0 of the vaccines. So from that point of view, I think a vaccine mandate is kind of premature. And that's part of the reason why the government said they're not going to mandate the vaccination, but they've come pretty close to it, with the rules about the malls and the coffee shops and those have created chaos.
Yes.
Because, and also the rationale is a bit hard to understand, because if the vaccine doesn't work very well to prevent transmission, then effectively what you're doing is you are, I guess, you're actually telling the person, don't go to this place because you may get infected. It's not because you're going to spread it to somebody else.
Right.
So it's a self-protection thing rather than protecting the community at large.
Right.
And then the other thing they're arguing is that maybe this is where you might end up getting infected if you go to a mall or a coffee shop. But the number of outbreaks, there have been a couple of outbreaks in malls like at Gem and at Jewel, but by and large the bulk of the outbreaks have been in nursing homes, they've been in workplaces, they've been in households. So banning people from going to coffee shops or hawker centers, which are open air, is not going to work. And we've had huge outbreaks in markets, but they haven't banned people from going to markets. Yeah. So it's a bit confusing, the messaging, and I think the public health benefit is minimal, but the cost in terms of the trust, in terms of the buy-in from the people, is not there.
And the mental health of the people,
exactly.
The frustrations, the confusion.
With the changing rules and the exceptions that get put in, and
it's crazy. I mean, it keeps changing.
Yeah.
I guess the environment keeps changing, but from the mental health aspect, it can be very taxing. Very confusing.
It can be extremely taxing, and unfortunately, it drives people to try and break the rules, which is not a good thing, and that affects people psychologically. People have been law-abiding all their lives. They get a permission to go and see the doctor in the mall, and then they want to stop by and get a cup of coffee. And that's against the rules. You see? But somehow they do it, and then now you're a criminal. So
no coffee for you.
I know, that's so sad. Yeah.
Okay. We'll now talk a little bit about the 8-point plan that SDP has put up, and I will ask Dr. Paul to actually go through it. Yeah.
Okay, so the very first point is to stop testing asymptomatic people. Now we got some good feedback on that. First thing was that I originally said asymptomatic unvaccinated people, and somebody wrote in and said, look. Vaccinated, unvaccinated people have the same viral load. So we are going to drop the vaccinated people. So we're going to say stop testing asymptomatic people regardless of their vaccination status. The second point, which was brought up by some of my colleagues, is that there are certain people that we do want to test when they're asymptomatic. And these are going to be like our sentinel populations. So they would be like people working in nursing homes or people who have the risk of transmitting infections to very vulnerable people. So for those people, maybe we could do periodic. We don't have to do everybody all the time, but we could do sentinel surveillance at various time points.
So selective, targeted
testing,
rather than
blanket.
Yes.
And frankly, it's a huge waste of time. It consumes a lot of resources, You know, these ART kits are not expensive. A patient was telling me this morning, she said she's paying $10 for a kit. Her son had been exposed, he had to be tested every day. So the cost is actually quite significant. And there's also a false positive rate with the ARTs. So that creates a lot of anxiety, creates fear, and it's something you've got to deal with because they're not as accurate as the PCR test. But on the other hand, you don't want to do PCR testing every day for a kid at home.
After all, if you are asymptomatic, your viral load is a lot less.
It's considered lower, and your risk of spreading is also lower. So people who are pre-symptomatic, they do spread. But you know, by the time you get symptoms, then you go and seek attention. And if necessary, if you're in a vulnerable population, they can do contact tracing, or they can alert the people who've been exposed to you in the past.
Right. Okay.
So the second point was on the focus on primary healthcare. Primarily the GPs. The GPs provide 80% of primary healthcare in Singapore. 20% is provided by the polyclinics.
Okay.
And you know, in the SDP, we've long felt that the core of healthcare in Singapore has got to be primary healthcare.
Yes.
You know, it makes a lot more sense to subsidize the treatment of hypertension than to wait for somebody to get a stroke, right? So we believe in empowering the GPs, in paying them appropriately so that we already have the PHPCs. So they can do swabs for individuals and they can follow up on patients.
Yes.
I mean, GPs treat the bulk of the dengue in Singapore. They treat conditions like chickenpox. They treat hand, foot, and mouth disease.
That's true.
So endemic infectious diseases are not new to them. They know how to take precautions. We've had more than a year and a half of this pandemic. So I think that is going to stay.
And it makes sense.
Yes, thank you. So number 3 was in-place recovery in nursing homes. Now this one we got some feedback from the nursing home operators, and they said, frankly, you know, it's very hard for us to do that. So we took that into consideration, and I think we need to augment the medical supplies at the nursing home and medical manpower. And again, I would tap on the GP pool, because GPs are used to looking after elderly people, people with chronic medical conditions, but we also, and they are able to recognize those who need hospitalization. So, you know, I just saw a 90-year-old patient of mine, and when he got admitted, his daughter called me up yesterday and she was a bit worried. So I went to see him today and he was sitting there on his handphone. You know? And just because you're 90 years old doesn't mean that, you know, you're going to get very sick and end up in the ICU.
Sure.
Because age is just a number. So we need to move away from this protocolized treatment and let the physicians, the GPs, the polyclinics, the A&E doctors make clinical decisions.
Sure.
If you need to be hospitalized, you get hospitalized.
Sure.
If you don't need to be hospitalized, it doesn't matter if you're 90 years old. You can still be managed at home. Your GP is downstairs. Somebody can come and call the GP, or you can go down and get checked up later on. So the same would apply to nursing homes.
Sure.
You know, you stay in place unless you need hospitalization. And of course, you know, we should respect the end-of-life decisions of individuals. If they've made an end-of-life decision, then you know, the family needs to be involved, and they need to do the appropriate right siting of care, as they keep talking about.
Right.
The next one was on a dedicated ambulance service and hotline. And this is what we've heard from so many patients. See, that they've been sent home for home recovery. They try and call the hotline, nobody answers. They hear music, no support. And you know, part of the thing is that because the responsibility has been transferred to the poor people running the hotline, you know, when you're dealing with 2,000-3,000 new cases a day, it's really hard. And it's not that on day 2 people are going to stop calling the hotline because something has developed. They need to deal with it.
Sure.
So this is where putting the care back to the GPs, who, like I said, look after the dengue cases. They look after a lot of these endemic infectious diseases, and they're downstairs. You know, they're not sitting in some ops room somewhere.
And the GPs will know the patients
Exactly,
best.
the GPs know you, and they know, exactly. So they know, you see, if somebody says, I don't feel well, you know, it's a big difference between Mr. A and Mr. B. See, Mr. A may be saying he doesn't feel well all the time. Mr. B never says he doesn't feel well.
Right.
So they know which one is the one who needs to get an ambulance to take them over to hospital. And so the dedicated ambulance is like what we had during SARS, where people who are really ill can get appropriately treated without the A&E being clogged up by people who should be looked after by the GPs.
Do you think, there was a suggestion of utilizing some of the SAF assets. Is that
Well, I mean,
idea
you know,
to
the
put them?
SAF always wants to preserve its assets, but there are civil resources, and there are many of these which can be mobilized. So I don't think it's an issue of shortage of ambulances. It's a matter of triage. It's a matter of using them more appropriately. There's a shortage of staff, of paramedics, and again, this is where, you know, the SAF perhaps can help out. And I know that they are. In fact, I was talking to a surgical colleague of mine on Tuesday, and he's actually doing an in-camp training. And he said the very first week of his in-camp training, he and his medics, they went and did home vaccinations. And he said it was the best part of the in-camp training, because you sit there with this old person, you give them the jab, you wait for half an hour, you talk to them. And he says it was an eye-opener for the medics. You know, a lot of them have never seen the way these old people live on their own in these one-room flats. And he said it was a tremendously educational experience for them. So, you know, like I said, they're already doing that. So I think just stepping that up a little bit might help. But again, number 5 was actually reporting test positivity and clusters. Now, test positivity means that it tells you how many % of people test positive. Now, everyone looks at these league tables. Okay, country A has got 50 cases, country B has got 100 cases, but it doesn't tell you how many tests were done in country A. So if country A did 100 tests and they have 50 positives, that's a big problem, right? Because 50% of the cases are positive.
Right.
If country B tested 100,000 people and only 100 were positive, they have less of a problem.
Right.
So this is where the test positivity, we're not comparing ourselves with other countries, we're comparing ourselves with ourselves. So we're comparing ourselves on the 15th of October with ourselves on the 15th of September and the 15th of August. And the WHO has set a threshold of about 5%. If you're below 5%, the epidemic is under control. If you're above 5%, the epidemic is getting out of control. So there are some metrics that we can use, and I think we should use those. In terms of the areas of outbreak, now, you know, there's this very fancy map that's out there on the MOH website.
The red map. I thought that was the SDP map.
I know, it's all red all over. One day it could be. But, you know, the purpose of that map is not to tell you to avoid those places, because eventually you'll end up avoiding all the town centers, right, and boulevard.
So how is that useful then?
Yeah, so it's useful because if you were in one of those places in the last couple of days and you get a fever or a cough, you know, I would go straight to a GP and get yourself tested. Because it tells you that there's been a cluster in this particular town center. You know, although the fact is, as you said, almost every town center is involved, so it's hard to tell.
Because it's very endemic.
Exactly, it's all over the place. It's at a high level of endemicity. You know, HIV is endemic in Singapore, but fortunately the numbers are going down. So it's actually never been high level. It's been low to moderate, and now it's going to low. And that's what we want to do with COVID. It was low, it became high. We want to bring it down to moderate and to low level of endemicity. And that's what we want to do. So number 6 was targeted closures rather than a nationwide blanket. And I think I mentioned that to you just now. See, rather than shut down every coffee place, you know, if there's a particular outbreak in one place, we shut that down. And then we make sure that they follow the proper measures. We do that with food poisoning. You know, we have food poisoning outbreaks all the time. In various outlets, and they don't shut down every food outlet in that neighborhood. They shut down that particular outlet, and they go in and they clean it up and they make sure that, you know, they get their act together. So I think targeted closures is much more useful than a blanket closure. And we have the mechanism to do it. You see, we have the agencies in Singapore who have plenty of experience in doing this kind of thing.
Although I thought we need to update some of these measures, right?
We probably do. And one of them, I guess we were just talking about that, is the deep cleaning when you have one case.
Yeah, deep cleaning just for one case. And the case happened days ago.
Yeah, that's like shutting the barn door after the horse is bolted. See? Because frankly, people who, you know, 5 or 6 days later, there's probably no virus left on the surfaces.
That's right.
And I think that was appropriate maybe a year and a half ago when we were going for zero COVID, when we had 0 or 1 or 2 community cases. Now we've got thousands. It's completely inappropriate at this point in time.
It's not useful, it's not meaningless.
No. The next one was number 7, Intensify molecular epidemiology. Now this is a bit technical, but what it means is you do genetic fingerprinting for every virus. The UK has done that. They have got about 1 million viruses that they have actually sequenced.
Okay.
And that allows you to tell where the virus came from, how it's been spreading. So like, for example, in hospitals, they find a lot of healthcare workers who are infected. And at first they thought, oh, the hospitals are dangerous places, there's a lot of spread going on. Then they realized that actually when they did the DNA or the RNA fingerprinting, that most of these were related to their families. They caught them outside of the hospital.
Okay.
And then and then it changes your approach, because you realize that the danger then is a healthcare worker bringing the infection into the hospital, infecting a vulnerable patient. So your strategy has to change. In Singapore, we did this with the Hep C outbreak in 2015. So they did the RNA fingerprinting, and they found that the outbreak was due to a single clone, and that helped them to understand how to control the outbreak eventually.
So it's useful. It's useful in tracing, in tracking,
Right.
in resolving.
Yes, and Singapore has the ability to do this, and ideally it should be available at every major public hospital laboratory and the private the major reference laboratories in private hospitals. These machines are getting cheaper and cheaper. You know, it's like computers. You know, they used to be super expensive. Now these sequencing machines are getting cheaper and cheaper, and they're getting easier to operate. So there's a very good, in fact, one of the microbiologists actually texted me after we first revealed this, and she said, I strongly support this idea.
Fantastic.
So I think this is something that is well within our capability to do, and it would help us to really move forward in taking this on. And finally, it's trials on vaccines and therapeutics of non-licensed or novel products. And the two main things that I was looking at are the subject of intense social media debate. One is ivermectin. Now, ivermectin, we did a small study actually in the dormitories, and we showed there was some benefit. It wasn't statistically significant. It did have some impact, but we gave a relatively small dose. We gave a single dose. These people are arguing you should do it every week. There's a group in the UK which has actually started a clinical trial of this, and I know there are people in Singapore who are trying to reach out to them and to get this study underway. And I think there is a need to show whether it does or doesn't work in an objective scientific manner. The other one is the non-mRNA vaccines. There is a small trial in Singapore looking at people who got mRNA vaccines followed by inactivated vaccine. But I think we could do more of that, and that make these other WHO licensed vaccines available, but study them and see how they work.
Right. Well, that's the SDP 8-point plan. Now, under such a plan, I'm just trying to flesh out, what does, using the SDP 8-point plan, what does living with the virus, what would that look like? Say, for example, at home.
Yeah, you know, I'd love to say that it would go back to the way it was in 2019, but unfortunately it's not going to be like that. See, and the reality is that certain things have changed. I don't think anything at home will have changed beyond, you know, perhaps paying a bit more attention to hygiene, looking out for vulnerable or elderly relatives, but otherwise most of the rest would be pretty much the same.
Say the office, at work?
Yeah, again, the office and at work, you know, what has changed? That has changed dramatically.
Yes.
This whole work from home thing, although it primarily affects white collar workers, you know, cleaners, nurses, gardeners, these people can't work from home. You know? You can't program a robot drone to cut a fence or something like that. So, but I think a lot of people in Singapore are office workers, and it has awakened people to the possibility. You know, one of the biggest things in Singapore is the lack of flexibility in terms of working hours, and that's especially for those who are parents. Now, so many of them find that, you know, I've been in Zoom meetings where I hear a baby screaming in the background. And this has allowed people, both men and women, to participate in workplace activities while not neglecting their children. So I think that's a positive that's come out of this pandemic. The downside, though, is that the boundaries, you know, between work and home have gotten blurred. So, you know, perhaps we need a rule like in France where you cannot answer email after 5 p.m. or 6 p.m.
That's mental
like
health again.
That's mental health again, exactly. Drawing the lines. So I think those things that's changed, and that's a good thing.
All right. Well, that's an idea how the scenario will look like. You reckon masking still will continue?
Yeah, I personally don't like masks. I like looking at people's faces,
Yes,
and
yeah.
you can tell a lot from their reactions.
Yes.
I had a meal with somebody who actually is hearing impaired, and he said the mask was devastating. He
Yeah.
actually finally got himself a hearing aid because before that he used to lip read from people,
yes.
and you can't do that when they're wearing a mask.
Yeah.
But having said that, masks are useful in certain settings, like in hospitals, or as we mentioned earlier, in crowded public transport.
Yes.
So people probably will continue wearing masks in those settings.
Yeah. So, selected environment, mask is very useful.
I think so.
Yeah. More than that, something that can be looked
Yeah,
into.
I think that is also dependent on your level of anxiety and also your level of general health. You know, we have patients with cancer who really want to go out. This is again before the pandemic, so we just put a mask on them. They can go to Gardens by the Bay or wherever it is.
Okay. Well, let's talk a little bit about some other topics that has arisen. One big one of recent time is, of course, vaccination, right? So I thought we'd spend some time to talk about vaccinations. People are still dying. So, despite vaccination, so are they still useful? Do they work?
Well, you know, the MOH data is pretty impressive. And you take the results for people over the age of 80. If you were over the age of 80, 15% of them ended up either in the ICU or dying if they were unvaccinated. Right. If they were vaccinated, it was down to about 1.something%. Yeah. So there's quite a significant advantage, but it's not zero, you know, and this is where people get concerned. So 2% of say 100 cases is 2 people, but 2% of 10,000 cases is, you know, it starts going up. The numbers start right. going up. Yeah. So I think even though the vaccines are there, they're not 100% effective, even at preventing severe illness and death. But they are pretty good at preventing severe illness and death. I mean, 98% is not bad. Okay, it's not as good as some of the other vaccines, which are 99 to 100%. Sure. But you know, for a disease which is only about 2 years old, it's not bad. But I think they can do better. And I think the companies are working on improved versions of the vaccines. Other companies are also doing that as well.
Okay. So talking about vaccines, why is the need for booster shots?
Right. The need for booster shots is because the level of immunity drops over a period of time. And there's lots of data, and it's not just laboratory data where they look at your antibody levels, and that one we know after 6 months they drop quite significantly, but it's also the clinical data. And we've seen this. We see individuals who are vaccinated in February and March and they're coming in actually quite ill. And these are especially among the older people or those whose immunity is weaker.
So over time, for the older ones, the immunity starts to wane.
That's right.
And drop.
For younger people, it also drops, but we don't know whether that's enough to justify the booster shots. So in fact, the FDA has recommended, and even the WHO has recommended booster shots for older people and those whose immune system is weakened. The White House, on the other hand, recommends booster shots for everybody. Okay, so but maybe that's their call, and Singapore government has kind of followed that approach.
Okay, all right. Well, there's a lot of controversy for the vaxxers and the anti-vaxxers, right? The anti-vaxxers will be saying, "Oh, the natural immunity is the best, you know, from the community infection." How do you recommend we reconcile these two ends of the discussion?
Well, there's a paper from Israel which is cited a lot, which suggests that natural immunity protects you a bit more than vaccination. But I think there are a couple of other papers which suggest the best combination is you get vaccinated and you get sick. In that order, you know, you get vaccinated, and then if you get sick, you get a mild illness, and you have very long-lasting immunity. In fact, there was a study done by Duke NUS and NCID where they looked at people who recovered from SARS 17 years ago. You give them 1 dose of vaccination, they have super immunity. Wow. So that's kind of what we want. But you know, you don't want to take a risk. And so you don't want to get yourself naturally infected because you could be in the 2% who are going to get severe illness. So in general, the recommendation is get yourself vaccinated so that if you get ill, you know, if you get infected, it won't be so severe. And then the likelihood is that you're going to be protected for a very long time.
So better to take Because you never know whether you'll survive that.
Exactly. You know, like I said, you can't guarantee. You know, it's like you don't know what's going to come out in the 4D. So are you going to be in the 98% who do well, or are you going to be in the 2% that ends up on a ventilator?
Right. Yes. Now, talking about therapeutics medicine, how are we progressing so far?
Well, you know, unfortunately, we are not doing that well. I mean, interestingly enough, the most effective medication, the one that's recommended by the WHO, is a very old drug. It's a steroid called dexamethasone, and it's used for those who are severely ill, who need oxygen, who are in the ICU. It actually reduces the death rate. There are a couple of newer drugs which are so-called monoclonal antibodies, and these target various parts of the immune system. And there are contradictory results for many of them. Just recently, there have been some positive results on one of them, but most of these studies are funded by the companies that do them. So we need to get confirmatory data on that. There was a lot of interest in this drug that was developed by Merck. But you know, if you read the fine print, you realize that they actually developed this drug for hospitalized patients, and then they abandoned it because it didn't work. So they have two trials. One was called Move In, and the other is called Move Out. So Move In was for the inpatients, and that trial was abandoned for futility because it showed no benefit. But then the outpatient trial, now it's the preliminary results have been published in a press release, and it does seem to have some benefit because they reduced the hospitalization rate by an absolute amount of about 10%. And interestingly enough, there was no deaths in the treatment arm, and there were 8 deaths in the placebo arm. We haven't seen a peer-reviewed publication on that, but that top-line figure got everybody excited. The share price shot up and things like that. But there's a lot of concerns about the long-term effects of this drug, and so I don't really think it's a silver bullet. I think it may be useful in mild cases, but then again, how do you decide? See? You know, if 98% of people are going to have a benign cause anyway, see, are you going to give it to the 98% just to prevent the 2% who are going to get into trouble?
So still early days.
I think it is still early days.
Okay. Well, the last section for today's discussion centers around, well, SMM, social
Safe management measures.
Safe management.
There are too many abbreviations. I can tell you, somebody did a bingo, right, with all the different abbreviations, HRW, HRA, SHN.
I'll fill on that one. There's just too many. Yeah, so this safe management measures, so you reckon they'll still be necessary in the endemic world?
I don't think so. And again, you know, what we will have is targeted measures. Like, for example, you know, the whole point about this endemic state of the virus is what happens with every pandemic. From the 1918 deadly Spanish flu pandemic, which killed 1 in 30 people all over the world, after a while it became the dominant strain of flu from 1918 all the way up to 1957. Similarly with H1N1 2009, it became endemic. So it's just a matter of dealing with it. So we have endemic diseases which are potentially deadly, like TB, like HIV, and we do targeted measures. You know, in the old days, people used to, when they were giving an injection to somebody in a vein, there was a rubber bung and they used to stick a needle into it, and that's an easy way to poke yourself. After the HIV epidemic, they stopped doing that, and they're much more safe. They're much safer approaches to delivering intravenous medications, for example. Okay. So there will be targeted measures that will change. Like I said, things like work from home, things like widespread self-testing. You know, we've spent years trying to get HIV self-testing approved and publicized, and I think it's slowly starting to make progress. But you know, that would make a huge difference if people could do HIV self-testing. They could test themselves, and then they could go and you know, go to anonymous testing and get themselves treated. Sure. Because we know that early treatment can prevent complications with HIV. Yes. So similarly, you know, as we get more comfortable with the disease, we understand. It's like they say, you know your enemy, right? Once you know your enemy, you're able to deal with it, and you're able to make sure that it doesn't cause too much damage.
So it's similar to, say, the seasonal flu, where we know as the season, people getting it, we just stay away from those who are obviously symptomatic. Well,
yes and no. I mean, the seasonal flu, the thing about Singapore is that there's no seasons. But interestingly enough, we actually do have 2 flu seasons. Yes. In May and November. And the thinking among people who study this is that those are the school holidays.
School holidays.
So what happens is people travel and then they bring back different strains of the flu
Right.
when they're traveling. So I think that in that sense you're right. See, what will happen is that there'll be different strains of COVID in different parts of the world, and then when people travel, they might bring back a new strain, and then you get a small cluster here and there. But with the flu, we place a lot of emphasis on surveillance of nursing homes, on vulnerable people. We ramp up vaccination in seniors. We encourage healthcare workers to get vaccinated, those who have chronic illnesses to get vaccinated. So I think that will be very much on the agenda for COVID in the future.
Right. Okay. Trace together, safe entry. You think these are still needed?
Well, frankly, I don't think they work very well. I mean, we've had them for such a long time, and you still have like poor friends in the contact tracing center calling up people, trying to find out where they've been and identify the contacts. So they don't work very well. And so, frankly, I think it's a matter of time before we'll abandon them.
Since it's endemic, we really do not need that anymore.
Correct.
Right. Well, so less SMMs to be expected, but I guess it's a lot, as far as this COVID is concerned, is how do we live responsibly in such an endemic world? So responsible conduct, I think, is the way to go, all right, to manage this. If I were to ask, what 3 personal habits, responsible habits, should one adopt to get us through such an environment? What would
Okay,
what would
very
they be?
very good question. But I want to refocus it a little bit because health, a lot of it is beyond our control. And I think probably overriding any personal habits has got to be the need to hold those in authority accountable. And that includes people like myself. The medical profession, specialists. We need to be able to answer to the public. Explain why we're doing what we're doing, why we give recommendations, and also resource allocation. See, one of the things that has come through, if you look at the bed occupancy rates, which are published on the MOH websites, I mean, we are chronically short of beds. So it's not something new that just came out in the pandemic. And the reason why the healthcare system is not overwhelmed is because of huge sacrifices made by people who are willing to give up their elective surgeries, who are willing to postpone operations that they have planned out months ahead because all these things have been postponed or cancelled.
For the greater good.
Exactly, for the greater good or for the pandemic. It's kind of arguable about the greater good, whether putting someone who is mildly ill in hospital just because you're worried that they're going to infect their elderly relative versus delaying somebody's hip replacement, which and then he goes and falls at home. So it's a trade-off, and it's very hard to really pinpoint this or to have a one-size-fits-all approach. So the answer has got to be transparency, accountability from those in authority, and that has to underpin all of these things. So that's a caveat at the beginning. Sure. But ultimately, yes, good personal habits are important. And if you ask me to name 3, I would say number 1, personal hygiene. And I think we've done well with that, use of hand sanitizers everywhere. When I enter a room, I look for the hand sanitizer and go clean my hands. That's something that, wouldn't have come naturally about 2 years ago. Second one is making sure you seek medical attention. And seeking medical attention now has been broadened with the self-testing, with the ART. So many of my friends have called up and said, I don't feel well. Should I do an ART? I said, if you think about it, you should just do it. And then you can, if you really feel unwell, go and see your neighborhood GP. So personal hygiene, seeking medical attention if you're unwell, and then keeping up to date with vaccination. Now, Singapore is very good with childhood vaccination. With adult vaccination, we're kind of lagging behind. So I think this outbreak, or pandemic rather, has been a reminder that there are many endemic diseases out there that we need to make sure that we are up to date with the vaccinations for, because they can protect us and they can protect those around us.
Yeah. So there are viruses of various kinds out there. It's gone endemic for quite a number, and COVID is in that stage.
It's the latest one of the lot.
The latest of the lot. Yeah. And what falls on us is to be responsible about it, how we conduct ourselves responsibly, and that's how we will able to manage through such an environment. Are there any other questions that has come on? No? Okay, perfect. We picked up all the questions.
Excellent, thank you.
Yeah.
Thank you to all of you who gave the questions early on too.
Well, this has definitely been a very useful and interesting hour that we just spent together. Unfortunately, the hour is up, and we have to end tonight's session, this episode here. Well, we hope these open discussions can continue through our various platforms, including future Ask Paul Anything episodes. So we thank you once again for all your questions, the opportunity to talk about them, and to you spending time with us. Now, until the next episode, we wish you a pleasant evening ahead.
Thank you very much.